Hello, everyone. Welcome back. We now have a distinguished panel, which will be moderated by Dr. Nilay Shah. It's my pleasure to introduce our moderator. Nilay Shah is a chair of the Division of Healthcare Delivery Research at Mayo Clinic and professor of Health Services Research in the Mayo Clinic College of Medicine. He is also the Robert D. and Patricia E. Kern Endowed Director for Research in the Center for the Science of Healthcare Delivery at Mayo Clinic. He currently leads the FDA-funded Yale Mayo Clinic Center for Excellence in Regulatory Science and Innovation, CERSI. He also leads the Mayo Clinic collaboration with National Evaluation System for Health Technology Coordinating Center. On the side, he is a great collaborator of mine. We write many, many papers together. Dr. Shah, floor is yours. We look forward to your panel.
Great. Thank you so much for the kind introduction. And I'm really excited about this panel and moderating this panel. My introduction in this space was back when I started my doctoral program many, many years ago. And my mentor at the time, Dave Kindig, the first book we read at the time was Why Are Some People Healthy and Others Not? And, the core of that book was really a lot of health outcomes are driven by non-medical care related factors and primarily social determinants of health. And so that discussion has been ongoing for many, many years, but in terms of actually interventions and what to do about it has been a challenge. And a lot of people, be it from the community settings, healthcare delivery settings to payer settings, have taken a great interest in that over the last decade. And I think we have an incredible panel, an esteemed panel that has actually done a lot of work in this space, because this is a struggle. A lot of people are trying to address these issues, but don't know what works, what doesn't. How do you go about making an impact here? So this will be a great opportunity for us as a group to discuss this and learn from the panel that we have here. The one thing before I turn it over to the panel to introduce themselves and speak more about their backgrounds, I also wanted everyone to be able to send questions throughout the session through the Q&A function, and then we'll have 10 minutes at the end specifically to address those questions, but we'll also try to address them as we go along in this session. With that, what I'll do is start with each of the panelists introducing themselves and speaking a little bit more about their backgrounds, the work they've done and where they are, and then we'll sort of go from there. So with that, maybe I'll start with you, Kathy, to introduce yourself and provide a little bit of additional context.
Sure. Thank you, Nilay. So I'm a healthcare operator. I specialize in healthcare delivery redesign for the most part, particularly for the Medicaid patient population. That has meant mostly serving super utilizers, as well as general population patients, but really looking for this constellation of complex health and social needs and helping that patient population in particular. So I think I've taken an interesting tour through healthcare, starting with pharma, and then on to hospital administration, and more recently payers, and now startups. So I thoroughly enjoy this work. At United Healthcare, I co-led the clinical redesign team, which is embedded in the Medicaid line of business. And the two areas that we focused very specifically on are housing, because housing is healthcare for some patients, and then primary care at home. So these were like deep social or super utilizer work, and tremendously satisfying. At the Urban Health Institute, which I co-founded in Camden, New Jersey, about 10 years ago now at Cooper Hospital, that was a pretty interesting assignment because institutes at hospitals are normally about body parts, bone and joint disease states, cancer. And this one was the Urban Health Institute. It was specifically for the Medicaid patient population. And that allowed us to do a lot of really innovative work around setting up an ambulatory ICU, an addiction medicine program, group visits, all kinds of very different ways of caring for the patient population. And we're really happy that we saw a 58% improvement in the margin with all of those changes. I served on the board of the Camden Coalition for a bunch of years when I was in Camden. I led the strategic planning subcommittee. Shout out for the Camden Coalition and all of the work it does to really develop a different language and a different approach to complex patients. So complex health and social needs, medical and social needs, is a way that they've been starting to frame this space, and I really appreciate the work that they're doing. I have to say that having run the COVID hotel exactly a year ago in Secaucus, New Jersey for 2 months was a very wild experience. And thankfully, all 100 of our patients recovered and went home, and none of our 24/7 staff fell ill, and there were a lot of them, between clinicians and housekeeping and food and New Jersey State Police. And thankfully, we did not have to set up 24 hotels across the state because the curve was going up, plateaued, and then started to come down. So that was really an 8-week engagement where my favorite moment was probably when a patient was getting in the car and headed home, and he said, "Your staff treated me like a person." And that's kind of what it's all about, right? So that's just a little bit about me. Thank you, Nilay.
Yeah, thanks so much, Kathy. I appreciate that introduction. And I'm sure we're going to dig in a lot more on some of the topics that you brought up there. Michael, maybe I'll turn it over to you to introduce yourself and provide a little bit of background.
Thank you, Nilay. Good morning, everybody. Mike Peterson, Chief Clinical Innovation Officer for NTT Data. My work started really in med school, where I really helped run what was called the Good Neighbor Clinic. And it was just my first window into not having grown up in lower middle class poverty, but to see how I can help care for people that grew up just like me. And what we took care of were a lot of undocumented patients, but also patients who didn't have a primary care physician. So it just started seeding in my brain, like how people have to exchange, come in and consume health in this way. Obviously went into pediatric emergency medicine and practiced for 12 years in an underserved community. And it was in this experience from these transactions, as Dr. Jane just said perfectly, which is that we are the model of how we care for patients is always reactive versus proactive. We're trying to evolve there. So what we saw, some things that stood out to me were the 2 a.m. patient who just came in for ringworm, and the lack of understanding from the staff as to why a patient on Medicaid would come in at 2 a.m, not realizing that the mom had just gotten off work from working her 3rd job, and the only mode of transportation was the car that the dad could bring in the child at 2 a.m. and or that the pediatrician's office was just booked for months and they couldn't get in. So all these barriers to health, but the really hallmark that I caught and this transactional experience of delivering care on the front lines was when patients would call 911 for an ambulance that wasn't technically, it's an emergency to them, but it wasn't a medical emergency, and that the ambulance system was being used for transportation. And this happens quite a bit, right? And we've tried to solve for that, right, by offering Uber rides. And then what I've learned in working in consulting is that this work is really hard, and you actually have to get into the streets. You have to understand these communities of color, underserved communities, that they're all not the same. The same community here in East Austin is different than East St. Louis, that is different than Minnesota, in Minneapolis. So understanding that you can't apply a one-size-fits-all. And I think what Kathy said perfectly is that we have to remind ourselves that we really are taking care of patients, but they're really people who have families, and they're not trying to be sick. They're not choosing to be high utilizers. They're not choosing these pathways. In fact, I'm sure they would rather not be in the hospital sitting in a waiting room in the emergency department and rather live their lives. So some of the great, really fun and exciting things I've been able to do and work as a part of is to really help use data as a currency, as an enabler with technology to help really try to help our clients understand how you can really get a granular contextual feel for the community, and then help using machine learning, predictive analytics to start to predict based on policy decisions, whether you try to support people with obesity and get them to lose 10 points on their BMI. With 100 people, there's $1 million savings there. And lastly, I'll say, along with all these, the work that we got to do, I would say that the challenge that we'll probably talk about later too is redefining ROI. a lot of chief financial officers for a lot of systems that you and you're working for, I've worked with. It's about the dollar amount and not so much about the quality of care or the non-ROI types of measures that they can, patient engagement, community engagement, things like, again, the quality of care HEDIS scores, all those things matter in the sort of calculation of solving for health equity. And the very last thing I'll say is that it is an investment, right? And that's how you have to think about this. There's a midterm, a short-term, midterm, and a long-term annuity. And if you invest into health equity, it will pay dividends in the long run. And you have to think about it around a 7-year window. So thank you for being here, and I appreciate the opportunity to join in this conversation.
Great, thanks, Mike. And again, I think you brought up a lot of different topics that we'll dig in on a little bit more over the next few minutes or next hour or so. And then Jen, would like to have you introduce yourself and provide a little bit of background.
Yeah, great. Hi, everybody. My name is Jen Frost. I am the National Director of the Thrive Local program at Kaiser Permanente. Thrive Local is KP's flagship social health program, which really seeks to address the broader social factors impacting health by connecting people to community resources and providers, and enabling a social care team through a network of those social services and healthcare systems working together on a shared platform. Our work in Thrive Local is really helping to inform Kaiser Permanente's approach to integrate social health screening and support into care delivery. And the social health practice of which I'm a part of is really core to the organization's strategic plan and commitment to health equity, much to the comments we just heard from Michael. As an enterprise, we are really working to elevate the role of social health to the same level as physical and mental health so that we're looking at the total health of our patients. Before joining Kaiser just over a year ago, I spent 10 years with United Health Group, most recently working on complex health and social needs work in UHC's Medicaid business, along with Kathleen Stillo, my co-panelist today. Prior to that, I held a diverse set of roles in, let's say, hospital administration, grassroots nonprofits, health policy consulting, health information exchange. I really tried to come at this from a number of angles, and I am really very passionate about the upstream drivers of good health. I'm excited to be here and share and learn with you all, and looking forward to our conversation.
Great, thanks, Jen. So I think one of the key questions that comes up over and over as a number of different organizations just across the board, be it community-based organizations, payers, providers, are trying to figure out how to address social determinants of health. And one of the key challenges, at least that I've heard, is they don't even know where to start. And one of the key issues is how do you identify that, be it the right population, or how do you leverage data and technology to better address this at a population level? So maybe Kathy, I'll start with you to see if you have any thoughts or experiences that you can share as people are thinking about addressing social determinants of health.
Sure. Well, I come from a lineage of hotspotting, I'd say, and really making sure that we are able to look for, in the claims data in particular, medical and social complexity. And that means addressable spend. It has meant, for the work that I've done, addressable spend that goes beyond $100,000 per year in medical costs. Because once you see someone who's got that much medical utilization, there's a whole constellation of other things going on around them. And, in my mind, I've sort of sketched out, like, it starts with data. That's literally where we're starting, is we're hotspotting, looking for superutilizers. It ends with data, meaning what happened? Did we get a result? And in the middle is what I would call care fulfillment. That's actually creating an impact on folks. And, when does that go well? When the algorithms are really well designed. It's easy to get very kind of whipped up around risk stratification and some, complicated stuff. Like, for example, if you're including pharmaceutical spend in your dollar number, just toss it out. That's not something you're really going to be able to affect. And so as we did a lot of fine tuning, it became more and more clear who truly was in a super utilizer state. And I think that's a really good starting point. It's hard to then act just from that. You're hot-spotted data dump list of 100 people, that's not enough. You can't just start throwing programs at them. You really need to do a case review. You need a clinician or a health coach, someone who has an actual interaction with the person, who can represent them and present their case, and do it with what we call the patient review board, which was very effective. Senior leaders, cross-functional, really sitting down and looking at cases together and saying, like, okay, how do we understand this? Where is there an intersection with programs that we're leading that can match up with what the patient's needs are? And where do we think we'll get a response? And that's it's a topic that's easy to not even want to say that word, right? Like, who's going to be a responder? But the truth is, who's going to be a responder is a really important question to be asking, so that you're matching the right programs with the right patients. Because the worst thing is to throw very time-intensive, resource-intensive programs at patients who are just not going to be able to respond. And that's about readiness for change. It's about a whole lot of things. But that's a really important aspect of being able to show ultimately an ROI with the programs that you do run. And I would say it's fair to consider it that way. Yeah, I think I'll leave it at that and pass it on.
Yeah, the one thing I'll just dig in a little bit more, you mentioned this dollar threshold, and oftentimes I think you constantly hear that top 5% population, and typically I think in healthcare we all know, the 20% account for about 80% of the spend. And have you noticed the differences as you think about sort of targeting which population? One of the questions that's come up is it the top 5% or that next 5 to 10% or 5 to 15% where there's opportunities, or are we missing opportunities maybe for prevention in that group? I'm not sure if you had a chance to look at that.
I'm so glad you asked me that, because I've been thinking a lot about that topic these days. I feel like there is a rising risk for social complexity. And we talk a lot about rising risk for medical complexity. Like, Livongo is catching folks who have diabetes and hypertension before they escalate into a true superutilizer state. And that's brilliant, right? How can we do that on the social complexity side? So I agree with you. I think if we're only looking for the superutilizers, yes, there's the most opportunity for impact because the spend is so high, but the N is actually very small, which is the good news. Those really are tails of the curve. And if we start moving up the curve and taking more patients in and helping do more prevention type work, or catching them when they're in a sort of middling state and haven't hit superutilizer yet, I could feel really good waking up every morning knowing that we've caught people before they tipped into a superutilizer state. So, I'd make a big play for there's a way to start addressing rising risk for social complexity that I haven't seen happen so much yet, which I think is a big opportunity.
Great, thank you. Yeah, no, I agree. I think it's one of those things, even from a medical care perspective, it's the same issue, right? People are trying to sort of identify which are the right groups. And I think that's similarly with social determinants becomes a similar challenge. And Michael, you had mentioned sort of thinking about using data and technology as enablers in this context and working with different groups to do that. I don't know if you want to add or share some examples in that context that you worked with in the past.
Sure, it's a great question. And to follow up what Kathy said too, I think there is a notion around hotspotting and using data to help identify target, but there's this big piece that people often forget, which is engagement. Just because you know who they are doesn't mean that you can actually get to them. And when you what I'm talking about is using data to really get down to a population and really understand the attributes of certain personas, understanding that not everybody consumes health in the same way. So let's say you hotspot and you really think about somebody who are challenged by transportation and you offer Lyft rides or Uber rides or any ride share. What you will find is that the adoption rate is not 100%. And it's because we don't think, the social determinants of health, health equity, incredibly complicated, that just offering a ride to solve a problem doesn't account for that maybe the ride didn't have a car seat for the mom's child, or that they didn't have daycare provided for them, or that just wasn't convenient for them. So you got to really use data to know when to use those services. And so one of the things that I think in terms of technology is going to be around the digital experience. Now, we can talk about the digital divide in a second, but when we think about how people consume health, there's an expectation, whether you're affluent or truly poor, underserved, low socioeconomic status, that you expect the same experience as anybody along the whole spectrum. And it turns out people who are in underserved communities are actually better stewards of spend. I've seen some moms, when you say, hey, we can take an x-ray if you want, and most of the time Medicaid patients that I took care of were like, no, we're good, I'm good. But then if it's somebody's affluent, yes, I want x-ray, MRI, all these things. So there's this, I would say, there's an understanding of the people's personas and understanding how they consume that health. When I say digital experience, it isn't all about an app. I think you have to figure out what is the right experience for the right cultural, it's got to be culturally competent, and you have to actually provide equity in all of the design of this in terms of the algorithms, all the way down to make it community centric. So I like what Jen and her team are doing at KP, which is they're exposing help to a community, because we know that you have to go upstream. So there's a technology, whether it be a web digital front door, or if it's other ways that people engage. Some people, you just have to get old school and hand out flyers at the church. And so I think you have to be really, and I think where you had said, like, why is it difficult? It's difficult because at the sort of health plan level or very high systems level, they take a systems approach. And that systems approach is one size fits all. And there's a trust challenge that exists. And if you don't have those relationships at the granular level, it doesn't matter how much you offer. People have to know what you're offering and whether they trust you enough. So there's these, if you think about vaccine equity and how, and also hesitancy right now, the trust is a big challenge, and it's not going to be solved by one public health message. It's going to be solved by a series of conversations, and they're going to have these conversations at the granular level. So you have to leverage, as Kathy said perfectly, which is who are the trust brokers in the community, and often it's not the message, it's the messenger. So my experience has been that when I walk in the room and I see a patient who's African American, they're expecting Michael Peterson to be a white guy. And when I come in, they're like, oh, hey, doc, what's going on? And there's this instant rapport. And that's what starts that patient-doctor relationship and trust, especially in an emergency medicine perspective. So I would say that in terms of technology, there's a lot of shiny objects around AI and blockchain and all these really shiny things. They're great, but if they're not used for the right use case and they're not used for the right understanding, you're going to spin. And you're going to do a pilot and it's not going to work, and you're going to shelve it. And then people are like, well, we would try it. And I think we have to get beyond that type of thinking.
Actually, if I can chime in there, because you just said something that really inspired me. It's not about the technology, it's about the relationships. And that is something we have learned in a really meaningful way on the Thrive Local program, where we are building these networks and we've got the technology, right? We've got our vendor partner, Unite Us, and we've learned a lot along the way. But when you walk into a community and you say, hey, come join us on this journey, we want to build these networks where we together can be part of this broader social care team across our health providers and our broader community-based organizations. Unless you have a relationships reputation, you're not going to get much farther than that front door. And we have needed to really harness the power of our relationships. And we're building this with our communities. We are not building this for the communities. It has to be with. And that means that our communities have to be involved in the design, in the engagement, in the recruitment. And that's a big lesson that I think, we thought we would approach this in a very different way when we began this journey several years ago. And that's been a meaningful lesson for us.
Yeah, thanks, Jen. And I'm going to sort of build on that a little bit more. So you guys have done a lot at KP with the Thrive Local programs. How do you sort of go about sort of marrying data with the community partnerships and then ultimately sort of identifying the right population? Or maybe it's just really a community level impact that you are looking at, but it'd be helpful to sort of understand the broader process that you go through to have an impact here.
Yeah, and I think this gets to some of what Kathy was getting to earlier, which is kind of the many versus the few. And Thrive Local program certainly is kind of a more broad strokes, many oriented endeavor, right? This is for all of the members and patients in our communities more broadly that we encounter. And I think there's different types of programs that are going to be more customized and targeted to really specific patient populations to move needles around clinical, social, and financial factors. Whereas Thrive Local is really seeking to kind of pivot the way that we at Kaiser Permanente think about healthcare and broadening that consistently to include the social aspects and to look at that from a very total health and a total human perspective. And that means integrating it and making screening for social factors as common as taking a blood pressure, right? And so that's a real change management move, right? And moving beyond that medical model. But getting to your question around data, because technology, we're using the technology pieces like the Unite Us platform. And as I talked about, kind of there's so much more beyond the technology piece. On the data side, we are really looking to develop data-informed social health interventions and community partnerships that address inequity at scale. So that is kind of taking lots of different forms, and it depends on whether we're looking at this from the many versus the few. We do social needs surveys more broadly of our membership and learn things about that. For example, that social factors are the great equalizer across populations. This is not just a Medicaid problem. This is not just a Medicare problem. It is an everybody problem. I think COVID-19 has certainly taught us that in many ways. And we have community needs assessments where we look at the infrastructure of our communities. If we're showing populations and seeing through Thrive Local that we're sending a lot of referrals for housing support to a specific community, but we don't have in that community enough resources to meet that demand, that means something. And an organization like Kaiser Permanente can take that information and invest in the infrastructure, invest in the community capacity, while also investing in the programs that can help serve that need. So I think we're trying to look at the data need, looking at the data through many different lenses to understand that need from the capacity, the human, and the technology perspective.
Great, thank you. That's very helpful because I think it makes it much more tangible in terms of the approach you guys are using and for other organizations to sort of think about how to maybe learn from you or maybe opportunities to even partner with you in that context. I'm going to put Kathy on the spot here a little bit. This was a question that came up in the chat around or in the Q&A. What do we know about the effectiveness of these various programs, right? And how do we know when we are putting these programs, they have an impact? And especially in hotspotting, this is becoming a little bit of a challenge. The New England Journal paper was published showing it didn't have much of an impact. There's many reasons why that may be the case, but it also sort of brings up the question when you think about asking any organizations or others to invest in it, in any of these programs, to make sure we're deriving value from it, even from an effectiveness perspective. So how do you sort of, marry some of the results that I think that's the largest randomized trial that was shown, but and I think that there's been a number of pieces in the literature as to why that may have been negative, but would be really interested in hearing your perspective on it and how you sort of go forward to sort of make sure there's evidence and outcomes being generated with these programs.
Sure. So thank you for asking that question. Regarding the Camden RCT, I think really the punchline of that is that a care management program that navigates patients between inpatient and outpatient and tries to prevent a readmission is as effective as the system in which it exists. And this kind of concept of navigating to nowhere, like, if you're sort of pushing a patient from their inpatient experience into an outpatient world that can't handle their medical and social complexity and just isn't ready to do that work, then you don't get the result that you're expecting. I'm proud to say that the housing work at United, and there's a really nice article from Bloomberg about a year and a half ago that describes the results that we did get, with both hotspotting and then housing a smaller number of highly complex patients. So it was a 10 to 22% reduction in medical spend for that group of about 60 plus folks who were studied. And that's after regression to the mean, which is incredibly meaningful. So that's a great baseline in my mind, because it can only get better from there. And it did get better and better in terms of our way of hotspotting and our programmatic work with patients and making sure that there was a graduation, for example. So I'm very hopeful that we don't have a lot to start with in terms of prior work, but over the past, at least I would say 2 years, there's enough that's published out there that shows that you can anchor on a few numbers and say, this is the world that we're living in, and how can it be better from here? I hope that answers the question.
Yeah, no, that's very helpful. I think just that context of, that you mentioned is really important, that the context of how the program is designed and has a big impact on how effective it's going to be. But at the same time, I think, like you mentioned, as you continue to generate more and more evidence that they do have an impact, like the housing programs, hopefully we'll get more people being interested across the various sectors to invest in this. But that's where I think Michael's earlier point, I'll sort of bring that up, is the issue of ROI, right? So how do you have that ROI conversation or expectation, right? It's not very tangible necessarily, maybe if you're a plan, but how about if you're a healthcare organization or a community-based organization or others? How do you decide where you invest, and then how do you measure the impact, right? ROI turns out to be the easiest, or the one that's of greatest interest. But I'd be interested in hearing sort of your perspective, having done this with other organizations.
Was that for Kathy?
For you, Michael.
Oh,
sorry.
So I was just waiting because I was ready to jump. So it's a hard conversation to have, right? Because you're telling people to think differently, and you're asking them to trust in the answer, that you're providing them this insight. And again, there's low-hanging fruit, which you can have strategies around. And so really what you have to do is have a conversation around, what is your strategy to solve health equity? Do you believe in it? And is it championed from top down? Because if you're talking to the CIO, they're basically providing services to other consumers within the organization. And there's all these priorities, right? And so how do you prioritize health equity way above on top as part of a sort of guiding principle, if you will? So I think when an organization does make that investment in the technology and the mindset of where they're going to go on their roadmap, I think that helps. To Jen's point too, and even Kathy, is that you do start at the community level, and you have to understand your community that is surrounding where you are trying to help. So one great story that I love, a friend of mine, Greg Kotzbauer, worked as a consultant to First Health, and they said, look, we're trying to get in touch with this really rural, predominantly African-American community. And what they did is they didn't go in there with with parachuting nurses and doctors with, blood sugar tests and syringes. They actually had somebody go in and just talk to the leadership of that community, the sheriff's office, the pastor, several other key people on the city council. And they said, what do you guys need? They didn't say, oh, well, we would love a new hospital, or we would love A, B, and C. What they said is, we'd love a community garden. And if that doesn't tell you a little bit about how our lack of understanding, sometimes we assume people want things, and we have to really get to the root cause of what is it that they really want and need. And you can get to that by, again, using data to help you drive some of these. We understand everything about how Mike Peterson shops, how I consume health, how I consume other things. I'm not saying we have to get Big Brother, but I'm saying you can be iterative and really use that hotspotting idea, but you get a little bit more granular and get on the ground. There's going to be these ecosystem partners you have to pull in. So back to the story about the community garden, they brought in Home Depot, donated, all the stuff that they need. They had a gardener come in. And then within 2 or 3 weeks, they the leadership started saying, hey, there's 3 ladies down the street who are really having trouble managing their diabetes. Would you have somebody come talk to them? And it's these small micro interactions of positivity that started to build trust. So they didn't have badged people come in with their ID badge that says RNMD and we're here to help. It was around, they were dressed in like normal clothes and they were just getting to know this community. What that developed for Greg, and it's a great, we've got some great data around what he did, which is he developed this About Me card. And I know that we talked about, and Jen said it too, at the point of care, we need to think beyond just that care experience. When you go into triage in the emergency department, what's your chief complaint? When you go to the next level of care or in the emergency department, you get to the room, the nurse says, oh, what are you here for? I read that this, and they validate some information. The doctor says it for the 4th time. By the 4th time, no one says, if I prescribe you medicines, do you have the means to get it? Can you afford it? None of that is thought of. And so we have to rethink that sort of paradigm of clinical care management. And it turns out 70 to 80% of hospitals aren't even asking SDOH. They've got the screen. I saw when I took my daughter in to a hospital, there's this big wheel that Epic has on there, right? And I said, oh, that's amazing. Are you guys using that? And the doctor said, oh, no, I hardly ever use that. And that to me is a miss, right? Great design, technology, but the end user is not using it to capture the one time in someone's clinical journey to capture this important information is at that point of care, where then you can direct them to help. And then what you also want to be able to understand if that help resulted in some downstream clinical outcome or cost of care outcome. And so it's complicated, but they're not impossible. So what they created was this About Me card. Mm-hmm. And what it said is it allowed patients to write what was important to them. And you'd be surprised what patients write about. Some of them just say, I just want to be treated with respect. I'd love the doctor not to talk in very big words. All of these things help the clinicians understand when they saw them, they knew right away what not to say and what not to do, but also start to build that engagement and that trust. So that's just one of the things I would think about.
No, that's great, Michael. And as you were talking about the wheel, the other thing that sort of occurred to me is, we've worked even in our system that the data are being collected. Oftentimes the issue is then what to do with that. Mm-hmm. And so that may require an additional training or support for the clinical care teams, right, to make sure that be it connecting to social work or others as well, becomes an important component there.
Well, the data is only going to get more. There's going to be so much more of it, right? You're going to have IoT devices. You're going to have most of this home care. And what the problem is that most of the analytics teams I talk to at health plans or in health systems, provider systems, is they just say, Mike, we got this. We just need the instruction book on how to do brain surgery. We'll do it ourselves. And what they don't realize is they just want you to bring certain parts of data and then they're just going to solve it. And they're doing data for data's sake. When you have to do is you have to think about what is the use case and what question are you trying to solve with this data? If it's mother, baby, infant mortality, there's a whole set of data that you're going to want. That's not everything. So I think you boil it down to these really specific use case questions and answer those and be iterative in the process so that you can fast succeed and really drive down to finding the answer. Sorry, Kathy.
No, great. Thanks, Michael. Go ahead, Kathy.
I was going to jump in and just share my absolute favorite About Me story was a member who had spent 20 years as a hospital administration worker. So she'd had a long career. There were a number of bumps that turned her into street homeless and living behind a CVS for a number of years. And by the time we got her and we asked her, we were working on the My Purpose, we called it, which is the About Me. She said, I just want to have enough energy to do my hair and makeup twice a week. And that's not about hair and makeup, right? That's about, I want to feel good enough to be able to get out of bed and feel like the person that I used to be. And if we don't ask people that, we're not really figuring out what their primary diagnosis is, right?
Yeah, no, I think that's a key component, as trying to sort of integrate some of these into part of the routine clinical care. And sometimes one of the big challenges we're in is they're siloed, right? So there's somewhere this social determinants are addressed and the clinical care is here. And so we really need to think about bringing them together. The other piece of this that also is a little bit challenging, and Jen, you may have some thoughts on this, is, as you think about it from a community perspective, and I'm sometimes using the analogy of like employer-based wellness programs, right? So they're well-meaning programs, lots of programs put out there, and sometimes the uptake is like 10%, 15%, 20%. Oftentimes it's the people least likely to benefit from those programs. And so how, or have the least need for those programs. So how do you think about these in some of the programs that you're developing at KP, that it's sort of getting, especially the population that, you know, in the community that is most likely to benefit of those from those programs, or get them engaged early on?
Yeah, no, I appreciate that question. I think it's about a couple of things. It's about the messenger and how they're trained. So motivational interviewing techniques, asking open-ended questions means a very big difference. You know, if you're asking somebody the yes, no of, do you have transportation to your appointment? Yes. But if you dig and you say, tell me about the transportation you have to your appointment, and you find out it's their sister, cousins, uncles, aunt who drives when she has her car periodically, that is not reliable transportation to their appointment. So it's about the messenger. I think it's also about the when you're catching that person. So for example, with Thrive Local, we've tried to create a number of different access points and are thinking about also the patient journey through our organization and where we touch the patient, where screening for social factors comes up, where connecting to address those things comes up. And so with Thrive Local, we've created a couple of places, right? So we've enabled our care delivery staff so that in the care delivery setting, we can have our physicians, clinicians, and staff enabled with screening tools and connecting tools to help address the social needs as they come up as part of our normal practice. And we should get into talking about normal practice, because the medical model today, you know, and quickly rooming people doesn't really allow enough time for those kinds of meaningful conversations. But we're also creating a kind of a self-service option where our members and patients can come take advantage of the phone book that we're creating, so to speak, to help them find resources if they're kind of feeling maybe that they don't want to have a conversation with somebody, but they feel equipped to kind of hunt for their own resources. We'll enable that in that way. And then we also have a call center we stood up so that outside of the care delivery setting, folks can, you know, feel comfortable also potentially having a conversation with a trained individual who has training in trauma-informed care and motivational interviewing and is equipped with the resources of Thrive Local to help go above and beyond to really connect folks and identify truly, you know, their needs. And while they do screening, they do it in a conversational style, right? It's not checkbox of, do you have food? Do you have housing? That you're not going to get very far with that. So they integrate it into the discussion. So maybe, you know, 30 seconds in, they identify that there's no food insecurity, but 10 minutes in, they're finding there's some income support needs or support with utilities that they've kind of surfaced as they've had these conversations. To Kathy's point, it's not about the hair and makeup. What's that root cause? What are the things that they're trying to accomplish, and what's kind of driving some of that need and what's behind that? So hopefully I got to answer your question there, but let me know if you want to dig deeper and anywhere.
Well, to follow up on Jen's point too, there's a stigma. When you start asking someone if they're food insecure, and however you ask it, you should want to do something about it. There's a moral injury if you don't. So what ends up happening by the time if you think of the longitudinal experience from the minute they walk in the door to the minute and they get this care delivery, the currency that no one has is time. This is an emergency department. The doctor is going to go off and go do a code. I've had to leave stitches in a kid to go do a delivery and just kind of go, I'll be right back, ma'am. You know, these are real world things. And when we screen, we have to screen with meaning. So what I think is when you have this confluence and this intersection of social care, healthcare, but there's also this behavioral piece, right? So I do think that we might dig into this, but if you don't account for that behavioral piece, you're going to have a vicious cycle. And we see this in obesity. We see this in a lot of other places. And we can't assume just because we provide all of these services that people are just going to instantly be healthy because now I have access to all these things. I can guesstimate that most of the places I've worked at in consulting where there's a breadth of people with means, when you look at their health, it's not any better. They're making bad decisions at every, I see it at airports when I travel all the time. So it's about education. And so I often joke and kind of think about it in a real way that if you really want to solve social determinants of health, again, in this long-term investment in annuity, is you start in 2nd and 3rd grade. Because when my 2nd and 3rd grader would come home, they told me all kinds of stuff. They were influenced. Dad, you're not supposed to eat that. We just learned that you shouldn't be doing that, this, that, and the other. And so it's also helping build resilience in certain underserved communities at that age that are mostly mental health and behavioral health that are going to be solved, that can't be solved inside the health system directly.
Yeah, no, and then I think you're bringing up the key issue most states grapple with, right? Education spending versus healthcare spending and the trade-offs thereof. And oftentimes, at least, many people feel there's underinvestment in education, where if we, address that early on, it could have a really significant long-term impact. The one thing, Jen, I wanted to come back to you in this context. One of the questions that came up is, how do organizations deal with ROI in the context of just doing the right thing versus just a financial impact? And I suspect the programs that you've developed have some targets or outcomes you're looking at. Is there a trade-off there that you guys think about from the KP perspective and sort of balancing those two pieces?
Yeah, this is such an interesting question. We're actually right now, like in the weeds, rethinking what it really means for the realization of hard and soft benefits for the Thrive Local program. Because I think, the programs for the few, where you've got, you're targeting that top 1%, healthcare cost individuals. It's a little bit more of a one-to-one where you can kind of find a path towards an ROI. I think the programs for the many, it's a little harder to find that ROI. And truth be told, right, making a referral to a food bank, is that solving the food insecurity? It's getting food in the cabinet for that week, but it is not solving necessarily the root cause, right? Which may be the income support tied to the housing instability and many other factors. So that is all to say, I think that's really complicated. I think organizations probably are diving into the health equity and social health programs because they're the right thing to do. And also there may be some long-term ROI, but I don't know that there's a clear methodology yet to master that, and that we're probably balancing developing some really targeted programs for some really kind of unique individuals who have severe needs and are accounting for a lot of costs that we can impact, like an impactable segment of the population. But that's going to be a really small end, to Kathy's point earlier as well. But that, that's going to have to balance out, the expense to kind of provide these broader social health kind of initiatives. The investment that Kaiser Permanente is making in Thrive Local is intended to transform the organization in many ways and how we think about and provide care holistically, and not necessarily so that we can see a decrease in our PMPMs or ED utilization, which of course we hope to see, but that that may not be the driving factor. It's that total health is more than just the ailment sitting in front of you or the physical health and mental health components. And it goes much deeper, and that we really need to kind of invest now in this early stages to kind of completely move how our organization thinks about this. And so, I don't think that we have solved this. I think this is something the entire industry is probably going to struggle with. That there is no sharp, clear ROI for a lot of these programs that are broad reaching peanut butter spread. And it's more likely for those small, but it's about balancing probably the two, so that the savings that you're making on one side can help balance out, the kind of less identifiable hard ROI, but soft benefits on the other side.
And do you, so what are the metrics do you look at least right now while you develop sort of ROI? Are you looking at uptake, number of more process type measures? How many people have taken up various types of programs? Are those the sort of short-term metrics to evaluate the programs?
Yeah, so in Thrive Local, we're thinking about, and we're still really early in implementation, so our user base is still growing, but we're thinking about how often people are using it. We're trying to get closer to using the system in order to connect people to services. trying to think about kind of what that throughput is. How long is it taking them to do that? Is there an efficiency component here? We're thinking about the members who are being served and or patients being served, and how many, what do they look like? What kinds of services do they need? We actually have some outcome data through the Unite Us platform, and you have to take it with a grain of salt. We can see that a case was resolved, for example, and you can see some more information about how it was resolved and what that can mean. And so we're looking at those metrics as well. But we're also looking at the community and whether the community is using the system and how often that's happening and what those use cases look like. So that's kind of, we're trying to come at it from those angles.
Great, thank you. I'm going to bring up just one topic that I think, Michael, you briefly touched on early on, but I think it's going to be critical, sort of how we leverage this, right? So is the digital approaches that are available. But with that, there's two challenges, digital divide, and yet there's more and more people that can be reached through those approaches. The parallel I also think about is the issue around loneliness. And for a lot of people, it's that human connection and the human touch that sort of addresses the loneliness issue, which, again, falls within this broader construct. So how do you balance sort of leveraging sort of the digital technology while making sure it doesn't increase inequities and improves equity, but also dealing with, on the other end, the challenges of loneliness, especially during the pandemic, that a lot of individuals across various age groups have felt, and looking for that human connection. So I don't know, maybe Kathy, I'll start with you if you have any thoughts on this. I'm sure you've thought about this with all the work you've done, both on the United side, Camden Coalition, and your current roles.
Sure, thank you. So I really do think there's a place for software as service to start to inhabit social determinants as well. I think of Noom, which is a weight loss application, the behavior change, the resiliency, the learning modules, like they're incredibly compelling and effective, and they're self-directed. And I think we haven't figured out in this space that we call social determinants of health, how to let people get some self-directed support, and that there is a space for that. I would never say that's the only way to solve these, because I agree with you, just kind of another non-live, interface is not necessarily what's going to help folks with isolation. And I agree that that's a huge problem. I have to say, I'm pretty compelled by these new supplemental benefits. For example, like companion care, which is people companion care, but also pet support animals coming to visit. Like, this is totally cool that CMS is now saying, right, it's not only the very traditional medical types of expenses that we'll cover, but in certain plans to really start to cover much more socially oriented types of supports like those in pest control and housing and transportation and food. And it's getting very interesting to see the normalizing of this. So my answer is, I think there is a space for a software as service digital support for folks who are in the middle of social and medical complexity. And I think the ones that are on the market are much more kind of medical only oriented at the moment. And I do also think that these very in-person ways of helping to make sure that people are not truly alone is important. And of course, this past year couldn't have shown us that more starkly, could it?
Yeah, no, I completely agree. And I want to see, Michael, if you have any thoughts specifically on that digital divide issue, right? And we are seeing that with the vaccinations play out really well, right? The people who are able to access them and leverage technology are able to find places and where they can get vaccination, and others who don't have that ability are sometimes being left behind.
Yeah, it's actually coined the phrase that I've had some conversations with partners, is that they are left behind. Social determinants of health or health equity are not going to be solved by one health system, one health plan, or one community-based organization. It's going to require a framework of different various partners who can do this. And one thing that I've seen in the consulting side is that you have to really, the lines are blurring and there's a convergence and intersection of these services. And you've seen it with how technology, especially telehealth, telemedicine, but you're going to start to see, more of the Walmart Health kind of getting in, the retail space kind of, kind of inculcating its way and, or, sort of migrating its way into the norm of health and everyday consumption of it, Best Buy Health. I think of my mom when I think of this, not the digital divide, but the consumption of that. So she has access to a son who's a physician, iPad, never uses, Alexa device she never uses, and an iPhone she barely uses, and doesn't. And I have to Uber her around El Paso. She's a widow as of October, and she is going to her doctor appointments almost once a week. When we think of somebody like that, or we think of someone who just doesn't have access to broadband, and some of the partnerships, as Kathy just described this, my mom would probably benefit from a program where there's a college student that is got some spare time and they come out and make sure that everything's taken care of. Whereas another may have a partnership with Verizon or Sprint or one of the telecommunication companies to really say, we're going to invest in this iPad that's got Wi-Fi enabled and the broadband for you, because we know that the cost of this, especially when I think of a use case like infant mortality or premature delivery, if you provide moms services between 20 and 27 weeks, she doesn't miss the ultrasound, she doesn't miss these vital labs, and these are the most important signs and symptoms you have to you follow up with, and then follow them through their 4th trimester post-delivery. You'll see a drop in significant, you'll see a drop in premature delivery, and that premature delivery has an ICU cost of care. So when we think of these health plans and we think of the health systems, there are some, clinical cost of care items that they can tie these by providing these services. And they do make some of these investments. Again, there's a limited view and they need to see it real quick. One last example I'll share is Henry Ford Health, along with Gleaner, a food pantry or food service nonprofit, did basically Blue Apron or HelloFresh for underserved community with a primary diagnosis. So they very, very focused on heart disease. And they had over 600 participants, 98% adherence. They all cooked their own food. They had to have basic, but the whole idea here was there was no app, but they did use some technology, but they went, so there's going to be a blend. And what I would say is as we evolve these solutions, quote unquote, you have to have a guiding principle so that when you're designing these, the people who are doing the schematics and the sort of research and understanding have health equity as their guiding principle, so that when they say, look at this amazing app, oh, well, great, no one can use it. So it's not that amazing, is it? So it's really, you gotta really think in that terms in everything you do moving forward.
Yeah, great. Thanks, Michael. I really think that's one of the big concerns in the AI ML space broadly, right? While there's potential for significant impact, there's potential to also increase inequities by, who are the beneficiaries of some of those technologies. So I think that guiding principle right up front becomes really critical in making sure that's measured throughout the process. The one question I think that had come up earlier that we only have about a minute or two left, but maybe Jen, I will pose this to you, is how do you partner with community organization from a financial perspective? So, if you're referring patients to them or members to them, that's increased burden for them. Is there, are there mechanisms through which, they can be supported as they have increased demand, or maybe even demand beyond the resources they might have?
Yeah, it's a really interesting question. The reality is our social work, patient navigators, community resource specialists have all been doing this work for decades. But with their Rolodex, their Post-it notes, their shared, sheets on their wall with the names of their contacts at the various resources they trust and know. So in many ways, the Thrive Local program is seeking to add some efficiency and more visibility and transparency into that process. And yes, I definitely think there will be an increased referral capacity. At this stage, we haven't seen that. But only because we're really seeking at the beginning to automate in many ways and use a different system for work that was already happening. But as we grow and we make this more of the common practice beyond the standard workflow of folks that already were doing the work of identifying and connecting for social health needs, that's when we're going to hit that kind of tipping point of potentially over impacting the communities. So a couple of things. One, we're definitely looking at the data. Our data allows us to see when a referral is sent and then somebody declines it, they can actually choose. One of the drop-down options is to choose that they don't have the capacity to serve that individual. So we're looking at that data and funneling that into our community health benefit information, where we have the strategy of the community giving dollars that Kaiser Permanente uses to kind of enable community capacity. So we're certainly going to leverage that kind of option for us as we move forward. And if we see trends in communities where there is an organization or a series of organizations that are continuing to decline for capacity reasons, we're also using all of our relationships to really listen and hear and partner with our community partners to understand what their capacity concerns are. We certainly don't want to just create a one-way funnel that just sends millions of referrals into our communities. So I expect us to kind of see as this grows what the impact is through the data, but also leverage those community giving dollars to help enhance the capacity of the communities.
Great. Thank you so much to all of you for joining this panel. This was really a great discussion. This could have gone on for the whole day, and really enjoyed the conversation. And thank you all again. And with that, I'd like to turn it over to Pinar.
Thank you so much, Nilay, for this really amazing panel. Thanks so much for moderating it so actively, so engaged, and loved hearing your perspectives. And thank you so much, Michael, Kathy, Jen. Really learned a lot from you. And I got a lot of ideas for my next grant proposal that I can put in, which means I'll bug each one of you for more ideas. But I also want to thank our audience very much and for joining us for this entire morning for this important topic. And please join us tomorrow again. I want to thank our sponsors, our presenting sponsor, United Health Foundation, our gold sponsors, Bind, University of Minnesota Office of Academic Clinical Affairs, Medtronic, our maroon sponsors, Frederickson and Byron, Stella Care, Blue Cross Blue Shield of Minnesota, and Mayo Clinic's Robert D. and Patricia E. Kern Center for the Science of Healthcare Delivery. We now encourage you to switch platforms. This is like what we have to deal with in the virtual world. Normally, we just leave the auditorium and have fun. But please join us in Hopin platform for expos and networking. We really have a fantastic group of sponsors who look forward to meeting you. And as you can see in the chat, Kim has put down the link for Hopin platform. Very easy to just join in. We'll keep the session live for a little bit, so you can just kind of keep, you can just click on it directly, and you must have also received the same email. Just a quick reminder, we actually have two different kinds of networking options. You can do a group networking. If you click on the sessions option, you can do sort of a group of 20 people join in a networking room, but you can also do a one-on-one randomly assigned networking. If you click on the actual networking button, it's like speed dating. And also please feel free to view the expo, and please join us tomorrow for a program discussing the solutions to prioritize health equity and social determinants of health. Thank you so much. I will turn my camera off now and go mute, but we'll keep the webinar live so you can click on the chat. Thank you very much to our panel again. Have a very nice day.
Thank you.